a quick disclaimer. The PSA series for Mind the Bleep has been created by junior doctors who have a passion for teaching, entirely on a voluntary basis, and the aim is to teach from experience and try and ease the pressures around the exam. I've tried to check the lecture slides and the contents to make sure they're accurate, but as always, we're all human and sometimes there can be mistakes. So Mind the Bleep don't take any responsibilities for any unintentional inaccuracies. If you do notice something, please send an email or comment on Facebook on the YouTube videos, and we will address it as soon as possible. The full T's and C's are on this link if anybody wants to have a look at that, please. This is everything we've covered to date. A lot of people ask sort of every time we have the sessions, are the sessions recorded and uploaded anywhere? Yes, they are. They're on the Mind the Bleep YouTube channel. So these are all the sessions we've already done, and they are all up to date. They've all been recorded and uploaded onto the Mind the Bleep sessions YouTube channel. Today we're going to be covering therapeutic monitoring, drug monitoring, and data interpretation. This is the PSA blueprint, so I'm going to try and cover as much as I can in this table that's been outlined in red. Structure of the session is always poll and chat-based answers, mainly poll. I think most of you prefer polls to chat-based. So without further ado, let's start with the first question, and I'll open up the poll. We've got a 64-year-old lady who's been in hospital for 5 days for treatment of a severe CAP, so chest infection. Her oral intake's been lower than normal due to having no appetite, and she's vomited twice and also reports seeing a yellow halo around lights. She's also more confused than normal. Past medical history of diabetes, hypertension, AF. These are the drugs that she's on. These are some of the bloods. So have a close look. In the exam, you should be given the ranges for the concentrations and ranges for the drugs. So you shouldn't be expected to know them yourself. And select the most appropriate decision with regards to this presentation. So I'll wait a little bit because there's quite a few that have joined today. So I'll wait for enough answers and then we can go through the answer. Now, one quick thing, you'll see sometimes in the exam, you'll have this sort of little arrow with a over an image or over something. Click on the arrow and it will make the image bigger. So this is what I want you to have a look at and see what you think. Well done to those of you that went for correcting hyperkalemia and taking digoxin levels. It's not incorrect to go for option A because you do want to correct the potassium levels, but you need to also take a digoxin level. This image here is called the reverse tick phenomenon, and you get that with digoxin toxicity. It's really interesting. If you ever have anybody in hospital, ask to have a look at their ECG if that's what they're suspecting. So it's kind of like it looks like a reverse tick. So what you want to do is take a digoxin level, and digoxin levels are normally taken 6 hours post-dose, but regardless of when they come in, I've specifically made this patient come in and it's been 6 hours, so that it doesn't confuse things, but take the digoxin level because we're suspecting toxicity here. A few things with digoxin toxicity. This is the sort of reverse tick thing I was talking about, and it's worsened in states of hypokalemia. So you need to do close monitoring of use and ease when you're prescribing digoxins, especially with diuretics, so things like furosemide, any diuretic that can drop your potassium. You need to be really careful, and just keeping things simple. Basically, digoxin and potassium use the same transporter in the cells. So if potassium is low, more digoxin, I believe that's the mechanism, gets taken up. So you're at increased risk of toxicity. And just a learning point as well, we see this quite a lot in hospital. If your digoxin, if your potassium level is low, then you should ideally do a magnesium level. You can just call and add it onto the lab, onto the bloods, because if potassium is low, then usually magnesium is also low, and you need to correct both. If you don't correct the magnesium, then the potassium will not correct very well. So it's just a sort of learning point there for when you're working. If you go into the digoxin drug monograph, it's got all the information here. So 6 hours after a dose is the monitoring, toxicity increased by electrolyte disturbances. So you need to do use and ease while they're in hospital. Another interesting thing with digoxin use as well, for drug interaction wise, if you're using it with amiodarone, dronadrone, or quinine, you need to use half the dose of the digoxin. If you're going from oral digoxin to an injection, there's also a 20 to 33% change that you need to make. So have a look in this section. It's really, really useful in the digoxin drug monograph. So we've got Case number 2. And just one thing I'll say, because I am on my own today, I'll try and answer the questions in the chat, but it might be worth waiting till the end so it's not too disruptive for you guys. So we've got a 36-year-old lady who's come to A&E with a 2-day history of abdominal pain and fever. She begins to vomit after a takeaway last night and thinks she may have food poisoning. She's got past medical history of gout, hypothyroidism, acid reflux, asthma, and hypertension. She's on these medications and her pregnancy test is negative. So what is the most appropriate option in regards to how she's presented? What would you guys do? If you're given a list of medications, have a look at them closely because it's most likely going to be relevant to the question. So I'll just give you a minute or so again. Great. It's really nice to see so many of you using the poll, guys. Nice and interactive. And remember, most of the things, a lot of the knowledge is sometimes you need to have pre-acquired knowledge, but a lot of the things you can find in the BNF, which is what the exam is trying to test you on as well, how to navigate it. So, right, let's stop the poll. So most of us have gone for ultrasound abdomen, using these FBCs, lipase, and LFTs. Fantastic. So well done, guys, for going for that one. Again, I can see why you've gone for the other options. So if they've got abdominal pain, you could and would need to rule out appendicitis. I think they would be more specific in maybe, right lower quadrant pain, those sort of things. You've just been told it's just general abdo pain. It's not unreasonable to do an ultrasound abdomen for appendicitis, but I think there's other things in the question that point towards a different answer. We've gone for using these in FBCs. Of course, that can give you an indication of how kidneys are doing, if someone's got an infection causing abdo pain. Cyclizine for nausea. Again, it's not wrong, but I think given that E says to do lots of other things as well, I think that's the answer we're kind of gearing towards. And again, IV paracetamol, it's not wrong, but the most appropriate in this instance is this ultrasound abdomen using ease. So if we have a look at why, the patient is on carbimazole for her hyperthyroidism. And if you go into the carbimazole drug monograph, important safety information. So on the left-hand side on Medicines Complete, it's really good. You can scroll down and you can click really quickly and go between these different options here. It can cause acute pancreatitis. So they have been reported. Don't know how common it is, but it's important to know that it can cause it. So that the test that we're doing is to try and figure out what's going on with acute pancreatitis. So gallstones, for example, can cause that. Lots of things can cause that. So ultrasound abdomen could give you a bit more information, and you wanted to do your routine bloods and also your lipase to see if it is pancreatitis, because that would be very raised. So well done to those of you that went for that one. Other important things with carbimazole, just to note, so it can cause neutropenia and agranulocytosis. It also causes congenital malformations with use during pregnancy. So it's quite a strong drug. Other drugs that can cause agranulocytosis also include clozapine and phenytoin. So it's good to bear in mind. Question number 3. So I think we have another poll. We've got a 45-year-old male. He attends his GP to have a review of his bloods following a 12-month check after starting statin therapy. He's on atorvastatin, 40 milligrams daily for his primary hypercholesterolemia. These are his blood results. Again, you'll be given the ranges in the exam, should be given the ranges in the exam. Select the most appropriate decision option with regards to the information above. Fab. Well done, everybody. So the correct answer actually is no actions needed, and they can continue on their current regime. So there's not always something you need to do. It's also good to know that sometimes you don't need to do anything. So if we have a look at why, if we go into the atorvastatin drug monograph, go into monitoring requirements on the left-hand side, it outlines here that those with serum transaminases, so we had ALT in the question stem here, so it's raised, it's 80, and the upper limit's 36 in this range that we've been given. So if they're less than 3 times the upper limit, then actually you don't really need to exclude the therapy, or you don't really need to do anything. If it was higher than the 3 times, then that's when you may need to switch drugs or have a look into the therapy. So monitoring requirements, have a look at what their requirements are. Another thing to note is creatinine kinase with atorvastatin. So before starting treatment with statins, you should, if people are predisposed to sort of muscle aches, things like that, it's good to do a CK level, creatinine kinase. And again, it's saying if it's more than 5 times the upper limit, then essentially you probably should avoid starting the statin. If you have look in the side effects profile here in the drug monograph, it mentions something about if patients are on atorvastatin or on statins and CK is raised, and we think the statin may be contributing, then you should hold the statin, repeat the CK level, and if the symptoms of myopathy, muscle pain, things like that have improved, and the CK level has come down, then you can consider restarting the statin, or you may consider switching it or restarting it at a lower dose. So a lot of times elderly patients get admitted after a fall, and a fall can bring your CK level up. If they're on a statin as well, it's a bit difficult because you're not sure if it's the fall or if it's the statin, but sometimes it's a clinical decision, but they may hold the statin, wait for everything to resolve, and then decide what to do. It's not really going to cause any harm to hold a statin for a week or 2 or even a little bit longer, because it's used as a 10-year risk reduction of strokes and things like that. So yeah, just important to bear in mind and be aware of. Case number 4. We've got a 75-year-old male who's being treated in hospital for a severe HAP, so a hospital-acquired pneumonia. He's being given IV amoxicillin 1 gram 3 times a day and once daily dosing of IV gentamicin. These are his blood results. You should have that in the question stem. Let me just double check. Yeah. The gentamicin was administered at 1 o'clock and a level was taken at 9 o'clock. So I've made this question up, but I've got the image from the PSA platform practice paper, so definitely have a look at that. Again, you might have a small image with an hourglass. Make sure you click on it. Here is the image enlarged. So this is what they want you to use. This is a nomogram. So with the information provided in the question stem, what's the most appropriate thing to do? This is essentially just interpretation of the levels, of the time, and the nomogram. So we've got spread of results again. The correct answer, well done, the majority have gone for E. Continue current dose, but increase the dosing interval. So this is essentially just using the nomogram and interpreting the information. So the dose was given at 1 o'clock and a level taken at 9 o'clock. So that's 8 hours later. So we go onto the monograph or onto the nomogram. And so this is time between the infusion and the sample drawn. So we want to go to 8 hours, and then we were told the level was 8 mg per liter. So then we go up to 8. And because it falls in this area, we would increase the interval to 36 hours rather than 24 hours once daily. If it was on the line, I believe you always go for the interval above to be on the safe side. So if the level falls on the line here, I believe it would be 36 hourly rather than keeping it at 24 hourly. So just have a look at all the information given. It shouldn't be complicated. It's just making sure you can read the nomogram. There's no reason to switch it to an alternative antibiotic just yet. If the levels were very high, then that's something you would consider doing. And yeah, and generally we don't reduce the dose. Normally we just increase the dosing frequency. So if you let me go back there. That's fine. So that's the correct answer. And generally with gentamicin, it's normally a once daily dose. Sometimes in certain conditions like endocarditis, pregnancy, there's certain things. If you have a look on the drug monograph, you can see why, which options you wouldn't do once daily. But generally it's once daily. And in the BNF, it says follow the hospital's guidelines on levels. So at our hospital, we don't use this nomogram. We take a level 22 to 24 hours after the dose, so 2 hours before the next dose is due. And then depending on the level, if it's less than 1, then we give the dose. If it's between 1 and 2, we increase the dosing interval. So you'll always be given the information you need in the exam. You're not expected to know the levels off by heart or anything like that. They'll probably give you a nomogram because that's what they've given in the PSA practice papers, but just be aware and just read the question carefully, and you should be absolutely fine with the answers. Here's the information about the once daily dosing and the serum concentrations. So you can see it literally says follow local guidelines. So again, gentamicin monograph, there's lots of information there. Have a look. Question 5, we have another poll. We've got Mr. Adams, a 45-year-old male who's commenced on azathioprine after failure to respond to several other DMARDs for his rheumatoid arthritis. So that's disease-modifying agents. That's his past medical history. And basically, yeah, so select the most appropriate decision option with regards to starting the azathioprine. All the information, most of the information should be in the BNF. So it's just knowing where to look. Super. So the answer is C. So well done. The majority of you have gone for C. The other options, I think I've been a bit mean. I'm not sure if they'd be that mean in the exam, but I've just tweaked. So I've gone into the drug monograph and I've just tweaked some things slightly to make the answers incorrect. You can find everything here in the azathioprine drug monograph. So if you have a look at the pre-treatment screening, essentially it says there's an enzyme called TPMT which metabolizes azathioprine amongst some other drugs here. Some people who lack the enzyme or have really reduced levels are at increased risk of azathioprine toxicity because essentially not as much, or if any, is getting metabolized. So you should ideally do levels of TPMT before commencing treatment, just to make sure these aren't the people who are on who essentially have no TPMT or very low levels. Other things, if you have a look in the monitoring requirements, and this is why most of the other answers are wrong. So full blood count should be monitored weekly initially for the first 4 weeks. Some places, some manufacturers say 8 weeks, and then reduce it to every 3 months. So that's why one of the answers was wrong, because I said every 3 months rather than weekly. And there's no, just because other DMARDs weren't suitable doesn't mean azathioprine won't be suitable either, I think, but nobody went for that answer anyway. And just because other patient has been on other DMARDs doesn't mean that you don't then monitor azathioprine levels because they've been on other ones. Have a look in the monitoring requirement section of the drug monograph. If it's something there, then it means it definitely needs to be monitored. So well done for the majority of you that went for the TPMT monitoring. Next question. We've got a 38-year-old female who attends her GP for a quick checkup after feeling generally unwell over the past month. She's been out of the country for the past 2 months on vacation. So she's feeling generally fatigued, but in the past week, she's had episodes of overheating and intense palpitations. She's also noticed that her clothes have become more loosely fitted despite no additional efforts for exercise or attempts to lose weight. She's got a past medical history of poorly controlled AF. She's on bisoprolol and digoxin for her AF, and she had to have her amiodarone stopped a few months ago because she had deranged LFT, so that's one of the side effects of amiodarone. What's the most appropriate decision option in regards to the information given above? Excellent. Well done, everybody. So the majority of us have gone for option D, which is the correct answer. So this is all about amiodarone. If we go into the drug monograph for amiodarone, have a look at monitoring requirements. So thyroid function tests should be performed before treatment, during treatment, and actually for quite some time after treatment, because the half-life is quite long and it can persist in your body for quite some time. One of the side effects of amiodarone is it can affect your thyroid, and it can cause hypo or hyperthyroidism. So in this instance, the patient is symptomatic for hyperthyroidism. She's losing lots of weight, she's getting palpitations. So well done to those of you who've gone for this. So we'll do thyroid function tests, and in particular, we want T4 and T3. Sometimes they don't add both T4 and T3 on the thyroid function test. So for amiodarone, they specifically want TSH, T4, and T3. So well done, those of you. The other options aren't necessarily wrong. You could refer to cardiology for their input because the AF is poorly controlled. You could increase the bisoprolol to manage symptoms, but essentially, because we've been told they've recently had amiodarone, that's what the question's trying to gear towards, and that's the most important safety thing, to try and rule out that, you know, whether the patient's got hypothyroidism or not, and very likely that they would. When you actually start working in hospital, patients with cardiac history, AF history, it's good to ask if they've been on amiodarone in the past, or if there's anything they've recently stopped, because they may, if you ask them, are you on any medication, they may not tell you that they'll tell you what they're on, but they may not offer up that they've recently been on amiodarone, because it can cause interactions with lots of other drugs as well. So that's quite a good thing to bear in mind. Another important thing is that they need to use sun protection when they're out in the sun, because it can cause a phototoxic reaction. It's quite rare to see. I actually saw it once when I was working as a med student. Everybody went to have a look, but it causes this blue man syndrome, and you get this blue discoloration of your skin, any areas that are exposed to sunlight, and it can take quite a long time for that to go away once you stop the amiodarone. So it's just an FYI thing. It's quite interesting. If you see it, you're probably not going to see it again in your work. So go and have a look. So well done, everybody. Question 7. Hopefully you can see the poll. It's just gone a bit blank for me. So we've got a 32-year-old female who's admitted to hospital due to being generally unwell. She's been experiencing more frequent vomiting and diarrhea. She has a mild tremor that's gradually progressed to become more coarse in nature. She's given IV fluids to rehydrate because she's been vomiting and has diarrhea, and she's also had her stool sent for C. diff because of these multiple episodes of diarrhea. For her investigations, because she's diabetic, they did a blood glucose, which was normal, and ketones were also normal. So NAD means normal. Past medical history of bipolar disorder, asthma, type 2 diabetes, and that's just diet controlled at the moment. That's her drug history. So have a close look at the drugs and decide what the most appropriate management option is. And again, most appropriate. Okay, well done, everybody. The majority of you have gone for the correct answer. So we want to send urgent lithium levels. We've had only a small percentage who went for commencing treatment for C. diff whilst waiting for stool samples. Normally, you'd wait for the stool samples to come back to see if it is C. diff or not. And in this immediate sort of management, because it's the most appropriate at the time, it's very important to send the lithium levels. I'm not sure, perhaps if you maybe just didn't see that they were on lithium, or you've not focused on that. But if you're giving drug history, just have a look at all the drugs, because they're going to be very likely to be relevant. So the patient is experiencing symptoms of lithium toxicity. So the most important thing is to send for lithium levels. So some of the symptoms can be here. So if you look at the lithium carbonate, there's a section for overdose. If you type in overdose, toxicity, poisoning into your control F, if you're not sure, then one of the things should bring something up. So if you type in control F overdose, it brings you to the overdose section of the drug monograph. So some of the things like vomiting, diarrhea, the most specific thing is sort of a fine tremor progressing to a coarse tremor. Those are the signs and symptoms of toxicity. And in this instance, it's quite helpful. You've got a link to the emergency treatment poisoning. So if we click on that, it tells you how to manage this sort of lithium overdose, poisoning, those sort of things. Essentially, you take a level, you'd need to speak to a senior and have a look on ToxBase, get advice from the National Poisons Information Service. Just wanted to highlight to everybody, if you do go onto this poisoning emergency treatment summary, there's lots of information on poisoning or for lots of different drugs. So this is just a snapshot, but I think there's probably about 20 different drugs and how to manage them. So definitely have a look at that section. So it's the poisoning emergency treatment summary section of the BNF. This is answers in the chat, please, guys, because there's 2 options that are correct. So very short one. We've got a 34-year-old female who attends rheumatology clinic to discuss the management of her newly diagnosed active rheumatoid arthritis. She's to be commenced on methotrexate. Select the 2 options that are incorrect in regards to methotrexate. So I'll just open up the poll. No, I won't, because it's answers in the chat. So I'll give you a minute or so just to have a look in the monograph, just to see if you can find what we're looking for the answer. So it's 2 answers that are incorrect. Super. Well done, everyone. Thank you so much for contributing. So the answer is A and C. So well done, Emmanuel. That's really, really good. I think so. The majority of you have noticed that you wouldn't be doubling the dose in acute illness. With steroids, you generally do, because when you're acutely ill, you need more steroids, and if your body's not making its own natural steroids because you've been on steroids for a long time, then you do need to double the steroids so that you're managing the acute illness. Methotrexate, often they actually stop when someone's acutely ill and restart when they're better. So well done, everybody. We definitely wouldn't be doubling the dose, if anything. It's not D. A lot of you have gone for D. So it can be taken before or after food. There's no specific recommendation that I'm aware of. If it has to be taken on an empty stomach, or if it has to be taken with food, then in the drug monograph, if you scroll all the way down to, I believe it's medicine forms, there's warning labels. And I've covered this in a previous lecture. If the warning labels apply, and I believe there's probably about 20 or 28 to that specific drug, it will say there that it needs to be taken with food or an empty stomach. And as far as I'm aware, it doesn't for methotrexate. So I believe you can take it with or after food. So that one is correct. It's not an incorrect answer. So the incorrect one is A as well, because skin should be protected from sunlight on a bright day. That's right. But it also needs to be protected even on a cloudy day. So in this question, I've put not necessarily when cloudy. So that's the bit that's wrong. So you have to avoid sunbeds. You have to use sun protection, but also even if it's cloudy, because the rays can still get through the clouds. So here we go. If you go into the monitoring requirements for the methotrexate, it says to have also full blood counts taken and liver function tests as well. So be aware of that. Some extra information as well for methotrexate. So again, have a look at the drug monograph. Everything about the sunlight exposure and stuff is also in there. So well done, everybody, and thank you for having a go. Any questions, just pop them in the chat. Otherwise, we have another poll. We've got a 55-year-old male who's admitted to hospital following an increase in cough frequency. There's no change in colour or thickness of the mucus compared to baseline. And he's also got shortness of breath. His chest X-ray is clear. So we often do a chest X-ray if someone's coming in with cough, things like that, shortness of breath, just to have a look at the cause. Inflammatory markers are unremarkable. These are his observations. So his respiratory rate's a little bit up. And he's saturating 86% on room air. Again, you may be given images in the PSA exam. If I just enlarge it for you here, this is the ABG. So if somebody is short of breath, things like that, we essentially would do an ABG to have a look at the oxygen component in their blood. So this is the ABG result, and again, you should be given the ranges in the exam. They're different also for each lab or each machine in the hospital, so you will be given the ranges. When we get the printout, we also get the ranges when we do our ABGs at the hospital. So based on this information, what would be the most appropriate course of action? Fine, thanks guys. Thanks all of you who've had a go. So the correct answer is D. Nobody went for the first answer. No one went for A. So the reason why it's not B is because if anybody who's admitted to hospital who's acutely ill, you would put them on a 15-litre non-rebreathe mask. So that's not incorrect. However, we've already done an ABG. So with COPD patients, this patient may potentially have COPD, and I'll explain why. If they're acutely ill, you put them on a 15 litres non-rebreathe, but then you do an ABG as soon as you can to have a look at their oxygenation and what's going on the ABG, and then you would adjust your masks accordingly, the oxygen accordingly. So because we have an ABG, it wouldn't be appropriate to put them on 15 litres non-rebreathe. And I'll go through the ABG in a second. So let's go through that now. So if we have a look at the ABG, the patient is not acidotic. So is it because of high biocarb? Yes, well done. That's really, really good. So basically people who are chronic retainers, their bicarb goes up. So it's essentially compensated. So because the pH is in the normal range, the bicarb has gone up over a period of time, and that's compensated to make the pH normal. Otherwise they would be acidotic because they're retaining carbon dioxide. So this is a picture of somebody with COPD potentially and a chronic retainer. So the pH is normal, the PCO2 is high, so they're retaining carbon dioxide, and the oxygen this is on room air, but it's low. So we do need to give them oxygen, and if somebody had 86% oxygen saturations and they didn't have COPD, that would be quite concerning, because essentially we want it between 94 and 98%. So, but this patient, the ABG picture looks like they have COPD. And in patients with COPD, we would aim for target sats of 88 to 92% and would use a Venturi mask. So I think some of us went for, did anybody go for the other option? I'm sure I made one with, so nasal cannula. So well done for spotting that the range had to be 88 to 92, but we don't normally routinely use a nasal cannula. We use a Venturi mask because it's a controlled amount of oxygen that goes in. We know how much is going in. So well done for spotting that. I was taught acute unwell, so you should still follow. Yeah. So acutely unwell you would. So thanks, Sophie. But you would do an ABG as soon as you could to have a look at the oxygenation, because what can happen if you give too much oxygen is you essentially switch off the respiratory drive, and then they can actually go into respiratory arrest, as far as I'm aware, because you're giving them too much oxygen. So you shouldn't, if they're acutely unwell, everybody that comes into hospital acutely unwell, you put oxygen on them. But because we've done an ABG, we have the ABG result, we now know how much oxygen to give them and what target to give. So that's all right, Sophie. So we wouldn't do NIV. Thanks for reminding me to answer that question, because they're not acidotic. 86% isn't horrendously low, because their target should be 88 to 92. If the patient was very acidotic, their carbon dioxide was going up and their pH the PO2 was very, very low, then they may potentially be a candidate for NIV, so non-invasive ventilation. But actually, this doesn't look horrendous. It looks like a chronic COPD picture, and they're being compensated. They're not acidotic. So there's some requirements. I don't know off the top of my head, but if you give it a Google for NIV, they would need to be acidotic, CO2 very high, PO2 very low. Have a look at the particular ranges, but I've specifically made this so that it's not a horrendous ABG picture. Otherwise, COPD patients, yes, we do consider NIV, but they wouldn't be candidate at the moment. I hope that answers that part. Is there anything else? No. So also, if you go into, because oxygen is a drug, if you go into the monograph, oxygen monograph in the BNF, have a look at the overview. There's a little bit here as well that talks about the lower oxygenation target sats for people at risk of hypercapnic respiratory failure. So these are the people I was talking about with COPD. They would fall in this category, and that's why we'd aim for 88 to 92. Anybody, as I say, who's acutely unwell, you don't know their history, they've just come into A&E, they're short of breath, their sats are very low, 15 litres non-rebreathe, until you can get an ABG, and then you can decide how to adjust their oxygen saturations. Okay, so well done, everybody. Answers in the chat for this next question. What Venturi percentage? So I think the Venturi percentage So somebody's asked in the group, so whoever's looking, for those of you watching back on the YouTube channel, because you can't see the chat, what venturi percentage? I believe it's a range. I don't know off the top of my head, but it's a range that you would use. And then you just adjust, you'd go between the range depending on what the oxygen saturations are. So if it was still below 88%, you'd use a higher venturi mask, but I believe there's a range, but off the top of my head I'm not sure. I can have a look and pop a comment in the YouTube chat or YouTube comments later, but off the top of my head I'm not sure what you'd start on. And I don't think you'd need to know that for the exam. I don't think it's in the BNF or anything like that. Have a look, it might be, but yeah, I think you'd be fine, and you'd probably be given that information. I mean, we don't know off the top of our head. We just kind of follow our hospital protocols for that. So next question, if anybody can answer in the chat, if you're brave enough. It doesn't matter if you get it wrong. It's great, because then we can go through why it's not that answer and things like that. So well done everyone who's contributing. So this is case number 10. I think we have 13 in total. We've got an 89-year-old female who's admitted to hospital, acute confusion. Her daughter reports that she's found her trying to shower whilst fully clothed and very confused. And this isn't her baseline. Normally she's independent and not confused. So investigations, chest x-ray was clear, urine dip was unremarkable. Normally we don't urine dip elderly patients because they generally come back positive, so we'd send a culture, but in this instance it was unremarkable anyway. Bloods are as follows. So have a close look at the bloods and see if you can decide what the most appropriate decision would be in regards to the management for this patient. There's 2 possible answers, please. Lots of A and Bs. So thanks, guys. I won't give you as much time because I'm conscious there's 2 more questions left. So the correct answers are B and D. So I can see why you went for A and B. You've noticed that the patients got low sodium, so that wouldn't be. I can see why you've gone for that. Well done. Some people have gone for D as well. So the reason why you wouldn't commence 0.9% sodium chloride immediately. So you've recognized that they're hyponatremic, but what we need to first do is a fluid status assessment, because the treatment for hyponatremia isn't always to give sodium chloride. If they're overloaded, sometimes you actually fluid restrict them. You wouldn't necessarily give them more fluids. So if they were very dry, so if they had dry mucous membranes and symptomatic and showing signs and symptoms of being dry, so not enough liquid in them, then that would be appropriate to start the sodium chloride. So if the urine output was low, things like that. But before knowing that, the first thing to do is to do a fluid status assessment. So if they're catheterized, then you'd have a look at how much urine output they're having, you'd have a look at their mucous membranes, listen to their chest, see if they're fluid overloaded, things like that. So depending on well done. So we've got a few Ds, some B and Cs. So the C is incorrect. So thank you for trying, Melissa. C is incorrect because, yes, we want to correct the hyponatremia, but we are not going to aim for the sodium to get to 140 in 24 hours. The maximum we can increase the sodium by is 10 millimoles in a 24-hour period. Otherwise, there's some serious consequences of that. So the sodium was 128. So the maximum we'd want to increase it to would be 138. So yes, well done. We need to correct the hyponatremia, but not that fast. The reason D is correct is because we need to, it's an elderly patient, they're confused. So whilst the sodium is low and it is an acute thing, we're going to cover that by doing a fluid status and then fluid status assessment and then managing that accordingly. But also you need to do a skin assessment just to make sure that the confusion isn't coming from an infection. I've said here inflammatory markers pending in the question stem. So the inflammatory markers might come back from the lab and be really, really high, and then you'd be kicking yourself if you've missed a pressure sore or things like that. So it's always good to have a holistic approach to these questions. There's no indication for an ABG because they're not overly breathless, their respiratory rate is normal, their blood pressure is okay, they're saturating 99% on room air. The reason we do ABGs is to have a look at the oxygenation. So if we're not concerned, then there's no reason to do an ABG. A VBG is useful because you get a quick response, quick result for electrolytes. potassium, sodium, how the HB is doing, those sort of things, but we wouldn't need to do an ABG. That's why that one is incorrect. Just some quick things again. So we've covered this, the rate of the increase. If patients are on PPIs, it's always good to review their medication. So if they're on, for example, omeprazole, lansoprazole, that can cause low sodium. So we can consider switching to something else that will also give gastroprotection, which is a drug called famotidine, which doesn't cause hyponatremia. Hold diuretics until you know what's going on, because those can also cause low sodium. And also review fluids and electrolytes. Have a look in the treatment summary. So in the BNF, there's a fluids and electrolytes treatment summary, and that gives you a bit more information about sort of how to manage these things. So we've just got 2 more questions. I realise we're almost at 8 o'clock, so sorry guys, I'll go through these quickly. I'll give you just a minute to see if you can answer these next 2. So we've got Mr. James, 34-year-old male, started on Clozapine because he's poorly controlled schizophrenia. He's tried 2 other agents. That's the criteria to start Clozapine. In regards to Clozapine, what are the 2 statements that are incorrect? So we want the ones that are incorrect. I'll just give you just a minute. The next question is shouldn't take too long, so hopefully we'll finish reasonably on time. And just as a heads up, guys, I'm going to just quickly pop this. If you could please send some feedback. The feedback rates have been a bit low for the last few sessions, and it's really helpful for my portfolio or all the other presenters' portfolios just to put this teaching and stuff in. So I'd really appreciate the feedback. It takes literally 1 minute. So I've just put the link in the group while you guys are doing these questions, the final few questions. So we've gone for B and D. Thanks, Alexandra. So I'll go through the answer just for the sake of time. The answer is, I've gone for B and E. So the reason it's B and E, if we go here, because we wanted the incorrect answers. Well done, Nadine. So have a look, go into the Clozapine drug monograph, monitoring requirements. Everything you need to know is in the drug monograph, essentially. So you want to do leukocytes, and differential blood count. We first want to do it weekly, and then you can increase the frequency accordingly depending on the levels and how the patient's getting on. There's a high risk of relapse, so you need to wean over I said withdraw antipsychotics. What else have you guys said? B and D as well. So there's another section that says to wean it over 1 to 2 weeks as well. So have a look at that. There's extrapyramidal side effects. I think that was B and E. Yeah, well done. So they are less common with second generations, so Clozapine in particular. So that's why that question is not wrong. And also with the hyperprolactinemia, it's very rare with Clozapine. So just have a look. The thing with the exam is have a look at the treatment summaries, have a look at the drug monographs. So if you go into the psychosis and related disorders treatment summary, you can find some of the information there about the extrapyramidal side effects and hyperprolactinemia. So I hope that's answered that one and why some of the other options weren't correct. What else have we got here? Yeah, so that's fine. I hope that makes sense. If you've got any questions, just ask in the chat. And then we've just got finally case 12. And I believe we have a poll for this, or we don't. Let me have a look. Stop that one. So we've got a 23-year-old male who's admitted to hospital following episodes of shortness of breath and chest tightness and wheeze, and he's a known asthmatic. His usual peak expiratory flow rate is 500. Chest X-ray is clear. Inflammatory markers NAD. These are his ABG results, and he's saturating 93% on room air. If I make this a little bit bigger, this is his peak expiratory flow reading. So roughly sort of the highest has been 390. If you can just answer in the chat, I don't believe we have a poll for this one, what we think the answer is here in regards to the asthma. Do we think it's mild, moderate, severe, life-threatening, or near fatal? And again, think about where you can find this information in the BNF. We've got B. Thanks, Aminat. Some more Bs. Fab. Excellent. So yeah, well done. It's moderate acute asthma. So I just wanted for you to have a look at the peak expiratory flow readings. You can have a look in the BNF asthma acute treatment summary, and it kind of explains what you need to do, what monitoring you need to do, and it outlines the level of severity. And in there, it talks about the peak expiratory flow rate, and it groups them into different severities depending on what the value is, percentage of normal, and also other things like respiratory rate, tachycardia, those sort of things. So just know where to find the information in the treatment summary. What else have we got? Yeah, lots more Bs. Well done, everybody. So I think that was it. Which of the 3 readings should we choose? So I believe you go for the highest one. So the best one that you can the best one that they do. So we'd go for the 390. We normally do best of 3 if they're not too breathless.